Good evening, viewers. My name is Rahul Desai, and I hereby welcome you all to our final milestone in our journey of 52 weeks of Diabetes Essentials with Dr. Sanjay Kalra sir. Dear viewers, these online modules are an educational initiative from Enerzal Zero and in memory of Dr. K.K. Agarwal sir. This journey of Diabetes Essentials of 52 weeks with Dr. Sanjay Kalra has been a knowledgeable journey for us as this platform provided an opportunity to learn many aspects regarding diabetes with practicality initially from Dr. K.K. Agarwal sir and then with Dr. Sanjay Kalra sir. This journey, which began from 26 Jan 2020-21, was a very experienceful journey. Like every journey which begins, it also should come to an end in order to start with a new journey with very new vigor and energy. In order to serve our family physicians, general practitioners, consulting physicians through this platform. So before I hand over this platform to Dr. Kalra sir to take us through today's module of diabetes in children, let me have the opportunity to announce the names of those doctors who have answered the quiz questions correctly in last episode. And the names are from Delhi, we have Dr. G.S. Batra, Dr. Rajiv Jindal, Dr. Manisha Kukreja Patla. From Karnataka, we have Dr. Anupama Swami, Dr. Ravi Bhatt. From Maharashtra, we have Dr. Damodar Jeswani, Dr. Jagruti Dabuwala, Dr. Harsh Shah, Dr. Seema Shah, Dr. Manju Vasudev, Dr. Javed Hassan, Dr. Then from Punjab, we have Dr. PKS Verma. From, from Uttar Pradesh, we have Dr. Ashwini Kumar, Dr. Suresh Kushwaha, Dr. Anil Upadhyay. So, dear viewers, in order to continue our endeavor at FDC to continue to support our doctors on medical knowledge updation front, we had started Hydration Diabetes series, which is a fortnightly series, and the first episode was aired on 18th Feb with Dr. Sunil Kota. Manmit, next slide, please. Dr. Sunil Kota, and the topic which was covered was Our Body, the Water Within. If any viewers who have missed to attend this session can view the session on the same platform. Our next session will be on 4th of March with Dr. Saptarshi Bhattacharya, who is a senior consultant and head of Department of Endocrinology at Max Super Specialty Hospital, Delhi. And this topic will be the endocrinology of water. And for this hydration in diabetes series, our host will be our very own Dr. Sanjay Kalra sir. Manmit, next slide. Next slide, Manmit. Moreover, viewers, in the next week on the MedTalks platform, we have a talk show on the topic of water and health. And this session is powered by Enerzal Zero, an education initiative from FDC, where the speaker will be Dr. Sunit Kumar Verma, who is as an MD at medicine at Department of Internal Medicine First Clinic Panchkula, and this session will be moderated by Dr. Sanjay Kalra sir. This session will be live at 7 p.m. on the MedTalks platform. So don't miss the opportunity to go through the topic on 24th Feb. And with this, I hand over the platform to Dr. Kalra sir to take us through today's module.
Thank you, Rahul, and good evening, everybody who is gathered with us today. Today, I'm using my wife's laptop, and this is the last in this series of Diabetes Essentials. But that doesn't mean that this will be the last in our interaction with each other. Like Rahul has already shared, we'll be meeting you in the hydration program. We'll be meeting you in KK Med Talks, and we'll talk about various aspects of health, of diabetes, of hydration. We'll also be kickstarting Diabetes Essentials Season 2 from next month, and I look forward to seeing you there as well. So, let's talk today about something special. Let's talk about our children. And why is it that we need to speak about diabetes in children? The reason is that, of course, diabetes has always been there in children, but usually it was type 1 diabetes. And now we have lots and lots of patients of lots and lots of children with type 2 diabetes. There is also a type of diabetes known as hybrid diabetes. Hybrid means a few symptoms of type 1, a few of type 2, a few clinical features of type 2, a few of type 1. So it's a mixture. Because of this, it becomes important for us as general physicians, as adult physicians, to understand diabetes in children. So let's talk about the unique aspects of diabetes in children. Now, in children, there is, if beta cell decline occurs, there is going to be a more rapidly progressive decline. If it is autoimmune, of course, it is type 1 diabetes. But even otherwise, if it is not autoimmune, the decline will be more rapid. So you will find that the children will move very fast if no action is taken. Note, if no action is taken, the children will move very fast to a state of first partial and then complete beta cell insufficiency. Along with the worsening of diabetes, they will also have worsening of diabetes complications. So there will be a much faster development of diabetes complications, both acute and chronic, both vascular and viscerometabolic. The risk factors for type 2 diabetes in children include a family history, adiposity, female gender, and low socioeconomic status. So, people from a family where there is diabetes, girls especially, those who are overweight, obese, and those who are from lower socioeconomic status are more prone to developing type 2 diabetes. Type 2 diabetes in India is there in children. We see these patients. It is quite common in Japan and it is fairly common in USA. It is recommended that we should not screen every child, but based upon risk, we should screen for pre-diabetes and type 2 diabetes after the onset of puberty or 10 years of age, whichever is earlier. So practically what that means for us is that for every child above the age of 10, we should have a high index of suspicion. If the suspicion is there, then we should screen. And we should screen every 3 years, at least, if not more. You have to do a fasting glucose, a 2-hour post-load glucose, and an HbA1c to be sure that the person doesn't have diabetes. Because some children may present with fasting hyperglycemia alone, others may present only with impaired glucose tolerance. What are the risk factors? We have just discussed them. Obese children, children with a family history of diabetes, girls, lower socioeconomic status, and to that, let us add children who are born of a pregnancy complicated by GDM. Children who at birth had a weight of more than 3.5 kg in India. So, macrosomic children, children born of a GDM pregnancy, these are also high risk children, and we must screen them for pre-diabetes. Other high risk factors would be children with other aspects of metabolic syndrome. We have spoken of adiposity, but if you have a child with hypertension, with with liver disease, NAFLD, or with dyslipidemia, again, screening for dysglycemia is mandated. If possible, antibodies should also be checked in children who have diabetes, even if they are overweight, so that you can assess whether they actually have type 2 or type 1 or hybrid diabetes. It is tough to distinguish between type 1 and type 2, but a few markers, though none of them is absolute. Overweight and obesity will be more common in type 2 diabetes, but it's not mandatory, it's not absolute. The antibodies, the pancreatic antibodies like islet cell antibodies, anti-GAD, they will be more commonly seen in type 1 diabetes, but it doesn't mean they can't occur in type 2. Ketosis, ketonuria, ketonemia, ketoacidosis, all will be more common in type 1, but can occur in type 2. If you have a patient with positive antibodies, islet cell antibodies, the progression to insulin deficiency, total insulinemia, is going to be much faster. So even if today you feel the patient is behaving like a type 2 diabetic, sooner or later you might have to change your diagnosis and then label it as LADA, hybrid diabetes, or just simple type 1 diabetes. In prepubertal children, type 1 diabetes is more common, but again, this is not absolute. However, if someone does come in with diabetes in the first year of age, in the first year in infancy, that is very rarely going to be type 1 or type 2. It will be what we call neonatal diabetes. This is a misnomer because neonatal period lasts only till 28 days. But the right scientific word would be monogenic diabetes. So, monogenic diabetes in the first year of life, type 1 diabetes up till puberty, and after puberty, it can be type 1 or type 2. This is a general rule of thumb, a general heuristic, but there is no absolute uh, black or white here. Now, is critical because the approach to patient will vary. The dietary advice will vary, the treatment regimen will vary, and outcomes also differ. Let's look at it from a type 2 diabetes perspective in children. You can offer lifestyle management, limited pharmacological management, and metabolic surgery in very special cases. Now, even for adolescents and for children, we have to empower them to be able to self manage. They should be able to self manage themselves. And for this, they need education, they need guidance, but they also need support. Whatever lifestyle program you create should be appropriate for the development of the child and also for the culture. But if the child is diabetic, has overweight or obesity, we should aim for a 7 to 10% decrease in excess weight. This is the best service that we can do to the child. Help him or her reduce weight by 7 to 10%. This can be done by very close contact, by ensuring behavioral therapy, change the behavior, introduce 60 minutes, not 30, 60, 1 hour of moderate to vigorous physical activity, reduce calories while ensuring high quality foods, adequate macro and micronutrient balance. And instead of being calorie dense in terms of food stuff choice, why don't we become nutrient dense so that in less calories, in less bulk, we can get more nutrients? We must focus on lifestyle, we must focus on exercise, but don't forget that children are also under a lot of stress. So don't push the child too much and ensure good stress management. And also ensure sleep hygiene. The child should be able to go to sleep on time and wake up on time. Glycemic targets have changed in the past 20 years. 20 years ago, we used to say that for children, we should have relaxed targets. But now, for most children and adolescents, we aim for a target less than 7, just like in adults. In fact, in selected individuals, you can aim for a target less than 6.5, as long as you don't cause hypo. But if there is an increased risk of hypoglycemia, then even 7.5 will be fine. You can even go up to 8 actually if you feel that there is no support for the child. The child is not able to express the symptoms of hypoglycemia. The child has hypoglycemia awareness. The child does not have access to regular glucose monitoring. Maybe insulins are being used which are not of good quality or which are being used in poor quality delivery devices. In such cases, we would want to relax the goals so that we prevent hypoglycemia. But for each child, especially when the child is on insulin, we should individualize the targets and discuss them with the child and with the parents. Ambulatory and real time continuous glucose monitoring can also be done. Now, we've looked at the approach. We have to focus on behavior, on lifestyle, on diet and exercise. We see that the targets are quite stringent. We don't have an excuse. So, how do we achieve these targets? Apart from the lifestyle management and diabetes education, we need to give drugs. So, if the A1C is less than 8.5 and there is no evidence of acidosis or ketosis, clinically or biochemically, then we can give metformin. You can give as much as 2 grams per day or as much as is tolerated. If the pancreatic antibodies come as negative, then we continue metformin. If required, you may wish to start insulin. You may also wish to start a glucagon like peptide receptor agonist. So, both are fine. If you start insulin, basal will be a good idea. But in India, most children do not respond to basal insulin. And in general, for all children, we would suggest a basal bolus insulin therapy. Now, if the A1C is more than 8.5 and still there is no acidosis, but there may or may not be ketonuria or ketonemia, but there is no acidosis, there is no respiratory compromise, and there are no signs of a low pH, Then again, you can give metformin plus basal insulin. And you can start with a relatively high dose, zero point 0.5 units per kg per day, and titrate twice a week. If antibodies are negative, then we continue with the insulin and continue basal insulin with the insulin and metformin as well. Now, in both these situations, however, if ketones are positive, the antibodies are positive, and also if ketones are positive, right, the child has acidosis and or diabetic ketoacidosis or hyperosmolar coma. Then first of all, you manage the emergency with intravenous insulin, and then you shift to subcutaneous insulin, and then you check the antibodies. And if they are positive, then we will continue with insulin. We will treat like type 1 diabetes. We will stop metformin. We can either continue multiple dose insulin, that is basal bolus, or we can start a pump if it is available. But in the vast majority of our patients in children, we will be using basal bolus insulin therapy. Now remember that this algorithm is for children and adolescents with overweight or obesity with a clinical suspicion of type 2 diabetes. So this will inform what you do initially when you have a suspicion of type 2 diabetes in the overweight or obese child. With time, within a few weeks, the diagnosis will make itself clear. You might have got the antibodies done. You might have just observed the patient, seen what is going on. And once you have a clear cut diagnosis, then you will treat accordingly. But in children and adolescents, it is just metformin and GLP-1 that are suggested. The other drugs like sulfonylureas and SGLT2 inhibitors should be avoided as of now. Very rarely, and I have not seen any child in my practice so far, a child with uncontrolled diabetes and severe obesity with a BMI more than 35 and also serious comorbidities may be referred for metabolic surgery. But I have not done that in my career so far. While we suspect diabetes, screen for diabetes, substantiate the diagnosis of diabetes, and also sort out the glucose control, we must be sensitive towards the development of complications. Now, all the complications that occur in adults can occur in children and adolescents. So we have to be careful. A disease like cardiac autonomic neuropathy can present within 2 years of diagnosis of diabetes. There are some extra issues that we must be careful about in adolescents. Uh, Early puberty, not necessarily the definition of premature puberty, but early puberty. Delayed puberty, both can occur. Polycystic ovary syndrome can occur in girls, and that can be a cause of distress. Sexual issues, reproductive issues. So you also have to counsel about sexual health and sexual safety, reproductive health and reproductive safety. These are in addition to the basic puberty and adolescent counseling that you will have to do if you are taking care of a child with diabetes. It's especially difficult to transition. So, if the child is under the care of a pediatric diabetes provider, they should begin to prepare the youth for transition to adult healthcare at least a year before transition. During this time, both pediatric and adult care providers should offer support and resources. They should pool them, and whenever deemed appropriate, the youth should be transferred to an adult oriented OPD. It will depend upon your acumen and your expertise, your interest as well, as to how long you wish to handle these youth. Today, we've raised an interesting topic, diabetes in children, type 2 diabetes in children, and I hope that enhances our curiosity about diabetes. I hope that it also enhances our resolve and determination to do a better job of diabetes care and serve the communities that we are working in. This is what we've kept on doing throughout this entire year of Diabetes Essentials. So let us see the quiz questions of last week. The correct statement was consultation with specialist does improve. It does improve the performance of tests related to diabetes management, such as foot examination, HbA1c, lipid, urine microalbumin, and others. The false statement was female runners experience less negative net fluid balance. They don't. They don't have less stamina and they experience exactly the same negative net fluid balance relative to body mass. Let's come to our questions for this week now. So, our first question, The risk factors for type 2 diabetes in children. We discussed them. Are they high intake of dietary fat, adiposity, diabetes in mother or father, or D, all of the above? So, what are the risk factors for type 2 diabetes in children? Dietary fat intake, adiposity, and parental diabetes. The second question is again related to adolescent diabetes. A 14-year-old boy whose 22-year-old brother has diabetes comes in with vomiting, abdominal pain, deep rapid breathing, and fruity breath in the middle of the night. In the middle of the night, he develops vomiting, pain abdomen, deep rapid breathing, and fruity breath. What should be done? One of the following is correct. Which is it? A. Stop eating. Wait until dawn to go to the doctor. B. Take antacids and NSAIDs. C. Family should check glucose at home to diagnose possible initial manifestation of diabetes with impending DKA, diabetic ketoacidosis. And D. Food poisoning is the most likely cause and that should subside without any action being taken. So let's repeat these questions again. The risk factor for type 2 diabetes are dietary fat intake, adiposity, diabetes in mother or father, or all of the above. And a 14-year-old boy whose elder brother is diabetic develops vomiting, pain abdomen, deep rapid breathing, and fruity odor in the middle of the night. Fruity breath. What should be done? A. Stop eating. Go to the doctor at dawn. B. Take antacid and NSAID. C. Check the glucose and suspect impending DKA. D. Think of food poisoning and do nothing at all. So, with these questions, let's go on to the audience questions for today. And there are lots of questions today. Let me take them up one by one. Dr. Surjit Kalsi says, we have become habituated to attend diabetes class on Sunday at 9 p.m. It will be preferred if the same timings are continued. We can think about that, sir, and perhaps we can broadcast this at this time also. Another thing is that I think all the classes are there on YouTube. They are archived and we can access them anytime we want. Dr. Parmar has a suggestion. We can include pubertal disorders, andropause, subclinical hypothyroidism, and osteoporosis in the next module. Certainly, sir. I will take note, and all these we will do one by one. Dr. Anshul has a few queries. Dr. Anshul is from Bhilai in Chhattisgarh. So, guide on the counseling aspect. When a child should take over the active role, and how often SMBG is advocated. So counseling is quite challenging. In children, it is especially challenging. Do not treat the child as a small adult, but do treat the child as an individual. Ensure 360-degree counseling. Speak with the child. Talk to him directly about diet, about exercise, and ask the parents to play a supportive role. Ask the child, is there any issue that you are facing, any stress, any challenge, and try to handle that. When should a child take over active role in diabetes care? As soon as possible, as soon as the child is able to do it. But the parents shouldn't push that as well. So each child will be different. Some are quite independent at 8 or 9 years of age. Others are still dependent at 14 or 15 years age. But we should try to encourage them. In our center, when we are speaking about diet and exercise, we address the child directly. I do that to the child. So I tell the child, this is what's to be eaten, what's not to be eaten. This is what will happen. These are the side effects. And the parents are listening quietly. Then when the child goes back home, he or she demands healthy food. The mother doesn't have to run after them. SMBG now should be quite frequent. So if your child is newly diagnosed, if the child is newly diagnosed, if there is a sudden change in glycemic status or in medical status or in medication status, let's repeat, if there is a sudden change in glycemic status, medical status, or concomitant medication status, or such a change is anticipated, maybe you are going to start the child on corticosteroids for a short period of time, right? So if this is anticipated, then SMBG frequency should be increased. Otherwise, if the child is stable, then you might get away with just 14 to 20 glucose values per week. How will you do those 14? In each day, in the week, there are 7 days. In each day, there are 7 points: three pre meal, three post meal, and one 3 a.m. So, 7 points. You can choose any two per day and try to do a structured or a paired glucose monitoring. So, you can do pre breakfast and post breakfast together, or pre dinner and post dinner together. That will tell you about the adequacy of the prendial insulin. If you want to check for nocturnal hypo, then you will do a bedtime, 3 a.m., and fasting glucose. The fasting glucose or pre breakfast will also tell you about the adequacy of the basal dose. So, this way, with around 14 to 15 glucose values per week, you can get a fair idea of what is going on. Dr. Jitendra Gangwani queries about the progress in stem cell transplant in type 1 diabetes. So, earlier there was a lot of hope, but now it seems to have been turned into hype. So, HYPE hype. So, there is not much of progress on stem cell transplant in type 1 diabetes. Dr. Bhavini raises a very pertinent point, and she says preventive aspects during gestation in order to prevent offspring. That is really true, madam. We cannot overemphasize this. So, the concept is called transgenerational karma. Before pregnancy, during pregnancy, after pregnancy, you can help your offspring prevent diabetes. That is by ensuring good glucose control and by ensuring breastfeeding, exclusive breastfeeding for about 6 months. All these are known to uh, preconception control, control during pregnancy of diabetes. They are known to reduce the chances of metabolic syndrome or diabetes in future life. And same is true for lactating. Dr. Gangadhar Rath talks about the various antibodies for classifying diabetes. There are three major ones: islet cell antibody, insulin antibody, and GAD. Anti GAD is the most important for classifying, but all have their own value. And immunity, severity of immunity, autoimmunity is also decided by the number of antibodies that are positive. So, if you have two antibodies positive, the chances of rapid progression are more. Actually, cost is an issue. We would want to get all of them done. If cost is a limiting factor, then anti-GAD is what we will choose in India. Dr. Vishnu Mulchandani talks about MODI in children above 12. So, type 2 diabetes is different. That is polygenic. Lot of environmental and lifestyle factors. That is type 2. MODI is genetic, it is monogenic. Only one gene is impaired. There is a strong family history. There will be three generations positive at least. So, grandfather, father, and son all will come with diabetes. Then you will suspect MODI. So, MODI is different from type 2. In type 2, chances of obesity are more, insulin resistance is more. In MODI, chances of obesity are less. There will be no or minimal stigmata of insulin resistance. One other screening tool that we can look for is acanthosis nigricans, because that is a pre-diabetic state. So if you have a child who has acanthosis nigricans or skin tags, these children must be screened for diabetes. Dr. Anand Purandare asks about diabetic nephropathy. In diabetic nephropathy, the ideal diet should contain zero point 0.8 gram per kg per day of protein. It is very difficult to achieve this in an Indian cuisine. So we should not reduce the proteins too much. Do a counting. The patient shouldn't be taking chicken or non-veg 2 or 3 times a day, but normal food can be taken. Milk can be taken. So 0 0.8 grams per kg per day is minimum that is required in diabetic nephropathy. And Dr. Gangadhar Rath again asks about SGLT2 inhibitors. So, yes, they are contraindicated in type 1 diabetes, even if there is no ketosis. I have written in the past, dapagliflozin was approved in Europe for type 1 diabetes, but the company itself has withdrawn the approval. They have asked for the approval to be taken back. So, we should avoid using it in type 1, even if there is no ketosis. If you have a child who is obese and whom you are sure has type 2 diabetes, even then, as per label, we cannot give below 18. But if you feel that it has to be given, you can give it off label, but do write a note on the prescription telling why you have written the drug, SGLT2 inhibitor. And then another doctor who sees, if some other doctor sees or you see after 5 or 10 years, at least you will know what is going on. Dr. Anandata Subramaniam shares the anecdote of some patients becoming diabetes free in old age. Yes, that may be because they are eating less. It may be because the beta cells have come back to normal. That is called diabetes remission. But more often than not, it is because of renal impairment. That is the commonest cause. So, renal impairment leads to lowering of insulin requirement. And when the patient becomes insulin free or OAD free, patient feels very happy. While actually, the reduction in drug dosage is because of kidney disease. So we have to check for kidney, liver, and gastrointestinal disease in such patients. The ideal HbA1c in children is also less than 5.7. So same values as for adults, but the target for diabetes control is 7, less than 7, again as for adults. Nitin Narula asks about any good supplement to increase nitric oxide. I think the best would be aerobic exercise, honestly, Nitin. So, aerobic exercise will make your blood vessels dilate. The blood vessels will become bigger and they will secrete more nitric oxide. So, the answer to that is uh, aerobic exercise to increase nitric oxide. Nitric oxide is a gas. It's not a solid or a liquid, so you can't eat it or you can't drink it. So we've had various questions today, and I thank all of you for joining us on this last day of Diabetes Essentials. This was season one. And like Rahul said, we will keep on meeting each other. We have a series on hydration and diabetes going on. That is every second Friday at 9 p.m. So the 9 p.m. time is taken care of Dr. Surjit Kalsi sir. We will also start Diabetes Essentials season 2 shortly. And in KK Med Talks, which takes place at 7 p.m., that is a mixture of Hindi and English. It is for public awareness. There also, on the 24th, we have a session on hydration and diabetes with Dr. Suneet Verma, who is from Panchkula. So I'd like to thank you once again, and we've completed all the questions. Back to Team FDC.
Wonderful, sir, that we have carried through the year, and thank to all the viewers, all the doctors who have guided us with their questions and make the interactive sessions came on every weekend. And as I feel that emotionally, that doctors are also saying that you know you keep continuing next week also 9 p.m. As you said, and Rahul has also said that we will be back very soon. Before that, I have two announcements to do because I personally feel that the journey of learning from top Indian doctor, top endocrinologists like Dr. Kalra continue with people who have joined with us. At the same time, we did an experiment on last 14th of November on World Diabetes Day, and we got Dr. Om Ganda from Harvard University, and we really enjoyed that talk. Actually, the talk was actually for 1 hour, and it ended up for 2 hours, and it was still we felt that it may could have continued. So that experience gave us another opportunity to get the best diabetologists or experts in diabetologists back with us. So we have decided 3 dates. Dr. Kalra will be moderating all the three sessions. So on 7th of April, 7th April, we have World Health Day. On World Health Day, we are going to have a special session with Dr. Sanjay Kalra. And the guest, please get the slides, Manmeet. And the guest doctor will be Dr. Vivian Fonseca, who's Assistant Dean of Clinical Research, Chief Endocrinology, Professor of Medicine in Toulouse, Alumni Chair Diabetes. And he's a big name. Dr. Kalra will be able to tell him more about him because he is from the field. I have got this very three names which I will be sharing with you. One is Dr. Vivian Fonseca, and the session will be on 7th April. So obviously this will be the start of our you can say the warm up session of season 2, where we can get the best diabetologists of the world and moderator Dr. Sanjay Kalra to start, and then the same day at the end of the session we will announce you the date of World Diabetes Essential season 2 with Dr. Sanjay Kalra. With this, I continue to say to all the viewers that we have lined up many programs, but you will be getting notifications through SMS on the same day. Probably we will try to get it one day advance also, so that you don't miss the dates. But once we are through from 7th April onwards, we are sure that that will be continuously every weekend or whatever date we come up with. With this, I simply cannot thank enough to Dr. Sanjay Kalra, because we remember that with the demise of Dr. K.K. Agarwal, we were clueless. How do we pull through? Because we were 5 sessions on, and we were looking at 52 sessions to go on. Dr. Sanjay Kalra helped us, and we thank sir that you've taken it up. And with this, I say Jai Hind to all the viewers, and keep tuned into our SMSs. And we will be back very soon with Diabetes Essential Season 2. And at the same time, all the notifications and sessions which we'll be doing on 7th April will be reached to you. And I do wish that all those doctors who have come and joined us in the midway can complete this course of 52 modules in the Diabetes Essential with their own email ID, which is reposited for the public viewing and for the general. We can say that knowledge is shareable, and knowledge is advancing, and the knowledge is getting updated. So we will continue with this. I thank you all, and good night, and Jai Hind.
Jai Hind.